around this room, I mean, many of us know each other, and there are many people sitting in this audience who know just as much about the ACA and the Affordable Care Act as I do and some others on this panel. So in the interest of keeping this moving, and let me just make a couple of points. I think building on what Brother Monahan said, there are certainly people who have benefited, and millions of people who benefit from the Affordable Care Act. And then there are those who are challenged by what's in the Affordable Care Act. And I'm assuming that if you're in this room, that you consider yourself among the challenged. Because most of us, or many of us, are trying to figure out how do you actually implement it, or how do you bargain for benefits for it, and how do you kind of move the ball forward in a collective bargaining environment, because when they built this bill, they really weren't thinking about this community. So we have to kind of make do with what we got. And Karen sitting next to me is in the thick of it in Washington, D.C., trying to figure out, so how do we change? Can't really change the legislation, certainly not with the legislative environment that's in there. So how do you do it behind the scenes through regulation at the various departments? And it's been a bit of a haul, as you can all imagine. So what I want to do in the short time I have is just kind of set the stage for the people who are going to speak after me. And I want to talk about a couple of things. I want to talk briefly about what's happened so far. I want to talk a little bit about the excise tax, because I think for whether you're a Taft-Hartley fund or you bargain directly with employers for single-payer plans, the excise tax looming out there is going to shape a lot of those discussions. So understanding what it means and what it doesn't mean, I think, is really important. I'll touch a little bit about the employer shared responsibility penalty, but I think Karen will speak more about where that is, because it's sort of in play, kind of. It's been delayed. And then we'll kind of see where we are. So what's happened so far? Well, basically what's happened so far is for those of us who provide benefits through Taft-Hartley funds or bargain for benefits have discovered that the costs have gone up. There have been coverage mandates with new benefits or required benefits. There have been the elimination of lifetime and annual maximums, which is a way of protecting plans. It doesn't really help participants, but it protects the plan sponsors. There's the distinction between grandfathered and non-grandfathered plans. If you're in an insured program, then odds are you're in a non-grandfathered plan, which means even more aspects of the law affect you. If you're in a Taft-Hartley fund in Massachusetts anyway, most of those plans have worked pretty diligently at trying to preserve grandfather status on the belief that sort of insulates them from some of the provisions of the Affordable Care Act. And there's an argument to be made that may be true, but it's a short-term, short-lived opportunity. Eventually, if you're a grandfathered plan, the law is structured that it'll be very difficult to maintain that grandfathered status. So there are rules around health reimbursement arrangements and HRAs and HSAs and FSAs. There's a real shift if you look at the Affordable Care Act and so much of what's coming in regulation and things like the private exchanges, the public exchanges, and then businesses getting into private exchanges. I think what we're all going to be facing is an increasing likelihood of looking at defined contribution plans in our health plans. And this is something I know that Peter talked about last year when we did the single employer session. It was a big discussion about, actually Warren Pepicelli spoke about it, it was a real move, that this law represents a real move from defined benefits in health and welfare, health insurance, into defined contribution. And what that means, what we all know, is that defined contribution plan means shifting more risk onto the participants. And there's a lot within the Affordable Care Act that sort of forces you to look really hard at doing that. It's a place that many of us don't want to go, but it's the conversation I think, unfortunately, many of us have to have. The other part of the Affordable Care Act that we're all dealing with is an advent or an influx of additional fees and in some cases taxes. So, what are some of the things that are applicable to all plans? We all know that dependent children or adult children up to age 26, not necessarily dependent as we used to think about them, but adult children got to stay on their parents' plans longer. As I mentioned, elimination of lifetime dollar maximums, restricting annual maximums, prohibition of rescission, the ability to put people off of plans, not having pre-existing condition exclusions, which in Taft-Hartley funds really didn't exist very much to begin with. But for people who are not insured, and in the insurance market, having pre-existing condition exclusions was an important part, of protecting those carriers against risk. Let's see. There are also the law put in a number of internal claims and appeal procedures. So there's a lot of information or a lot of aspects of the law that really help participants, whether it's claims and appeals, and be able to challenge what a carrier, what a plan sponsor says about whether you get coverage or don't get coverage, requiring emergency room services without prior authorization, so ease of access for people. These are good things, assuming you're not challenged with figuring out how to pay for it. Patient protection, and a lot of the advent of pushing more preventative care into health plans and wellness benefits. So preventative care for children, immunizations, preventative care around women's issues. There's a website that that under healthcare.gov, and when Allison puts up the website, on the website, the PowerPoint, you'll be able to see the link to it. But there's a website on healthcare.gov that says, here are the preventative services that plans need to cover. And it's an open list. It's not like, here's what the law says and here's what we're going to do. What the law said is, preventative services is important. It's a public policy. We want plans to cover them. And so as we decide, as decisions are made that there's an efficacy to a certain preventative service, there's a likelihood that plans increasingly are going to be asked to provide those services. So here's the list today, but don't assume that that's going to be the same list next year, because over time that list is going to grow. From a participant's perspective, that's a good thing. From the perspective of those of us who have to administer plans, it's a bit of a nightmare. All right. The ACA requires that plans begin to provide coverage for preventative drugs. 3 minutes, Rand. All right, and we're on page 9. So there's many aspects of the Affordable Care Act that are really pushing plan sponsors to figure out where to go. So what we've discovered, and you've discovered, is for the most part, the Affordable Care Act is costing money, and anywhere from 5% to about 3% is what we're seeing the cost in coverage to be as a result of affordable care mandates, taxes, and fees. So, putting on dependent children increased the cost of funds between 1% to 4%. Removing lifetime limits, relatively small, anywhere from 0.25% to 0.5%. The transitional reinsurance fee, 1% to 2% of cost. The transitional reinsurance fee, you all know, is that $63 fee, $5.25 per covered life per month. It's been the topic of much discussion. Everyone is expected to pay that fee in 2014. There is an argument to be made that many Taft-Hartley funds that are self-administered and self-insured, even if they're using or leasing a network in 2015 and 2016, won't have to pay that fee. But even still, for that 1 year that you have to pay it, it's a 2% increase in your expense. The comparative effectiveness research fee, $2, currently $2 per covered life per year. The PCORI fee, that sets up the institute that's going to be looking at the efficacy of what's going on in healthcare and making some of those recommendations of where you should be, where you're going to be making changes in things like preventative services and wellness. Non-grandfathered plans having to put in coverage for emergency services, preventative services, covering certain clinical trials, limiting out-of-pocket maximums, and provider non-discrimination, meaning that it used to be that you could require in a plan, for example, acupuncture. We'll only cover acupuncture if you go to a licensed acupuncture provider in the Commonwealth of Massachusetts with these credentials. Well, non-discrimination in provider means that you can't have those kinds of limitations. But that group of limitations, increase cost of plans by about 1 to 4%. So all told, you're looking at 5% to almost 13.5% increase in cost because of the Affordable Care Act. Is that good? Not when you're trying to figure out how to pay for it. Is it good because we're doing these things on behalf of individuals who didn't have health care before or who had inadequate health care? Yeah, that's good. But, we're going to be trying to figure out how to deal with it. In my remaining minutes, the excise tax. In 2018, there is an excise tax on plans that are considered to have rich benefits. We know, and that excise tax, which is a 40% tax on the amount of excess. In other words, once you hit that amount of $27,000 or whatever it is, depending on how you're calculating it, every dollar above that amount gets paid, is hit with a 40% excise tax. This was the Affordable Care Act's policy, public policy approach to dealing with cost control. If we put a cap on what you can provide without hitting a penalty, that will force plan sponsors and employers to kind of look really hard at the benefits that they're offering to make sure that they don't hit that cap, because who wants to spend the 40% excise tax? I mean, you don't get anything for that. There's lots of arguments that we can make about why this doesn't make sense and why it's a bad idea and why it's not the right approach, but as of right now, it's what we have to deal with, and Karen can tell us if there's a likelihood of that changing. Figuring out if you're going to hit that excise tax and when you're going to hit the excise tax is an important aspect of what you need to do going forward, and then looking at the strategies of how you deal with it. Going to a defined contribution approach and shifting risk onto the participants of the plan is one way of doing it, but there are other alternatives. And that should be the subject of an entire day-long session in and of itself. So we'll leave it at that, and I'll turn it over to Karen.